Hi, everyone. Welcome to another exciting live webinar sponsored by Fujifilm Visual Sonics. My name is Sarah Burris. I'm the scientific liaison here at Fujifilm Visual Sonics. And today we have a very exciting presentation given by Alwin de Jong entitled Imaging of Vascular Remodeling in Vein Grafted Mice. Now, before we begin the webinar, we just have several housekeeping notes for our group. In that, a recording of the webinar will be made available after the end of today's session. As a reminder, all of the lines are muted during the duration of the webinar, but if you do have a question, please submit that through the Q&A button located at the bottom of your screen. All questions submitted will be answered at the end of the session. Now, our talk today is expected to run about 25 minutes, and we'll have about an additional 5 to 10 minutes for questions after that. Our presenter today, Alwin de Jong, interest in science was triggered in 2014 when he started studying T-cell responses towards paramyxoviruses, yielding cross-reactive T-cells towards measles and hypnoviruses. In conjunction, measles virus vaccine strategies were tested in rhesus macaque monkeys, combined with microscope and microscopic fluorescence imaging. After his master's in biomedical sciences and medicine at Leiden University, he was awarded with a LUMC MD PhD grant. In 2018, Alwin started his PhD in the group of Margaret de Vries and Professor Dr. Paul Quax, focusing on image regulation in cardiovascular diseases. Currently, he works on the modulation of the immune system response to enhance vascular remodeling in order to reduce vein graft diseases. Imaging, both microscopically and non-invasively through ultrasound, are a great interest to Alwin. His images have been awarded with an honorable mention in Nikon's Small World Challenge and the University of Amsterdam and Leiden's Rembrandt Scientific Contest. Other awards are the Rembrandt Presentation, Dutch Heart Society Audience Prize, and the Visual Sonics Research Award for the European Society of Cardiovascular Presentation. And with that, I turn it over to Alwin.
I would like to thank you again for your introduction, and I would go back to the patient. And patients that suffer from occlusive arterial diseases, either in the coronary arteries or in the peripheral arteries, they need strategies to recirculate and reopen these arteries. And one of these methods is either balloon angioplasty or stent placement. But if the occlusion sites are too long or too diffuse, another measure is needed, and that measure is actually a coronary artery bypass graft or the peripheral graft. And the material for this graft is actually the great venous vein. And this vein needs to adapt to the arterial pressure, and actually that's inducing wall adaptations, which is recognized by the increase in wall thickness as represented in this image. This means that also the patency rates will drop because there is a decrease in lumen. That means that the patency rates for the coronary artery bypass grafts is actually 50% isn't included within 10 years. However, the peripheral grafts do even worse because in 50 to 60% is occluded within 5 years. So new strategies are needed to increase the patency rates of vein grafts. So after engrafting of the vein graft, there is denudation of endothelial cells, which triggers an inflammatory cascade. And from this inflammatory cascade, effector cells are migrating into the vessel wall. And thereby they induce an inflammatory surrounding that attracts more cells, and these cells are then differentiating. Eventually, they're forming a necrotic core, and that's also called the accelerated atherosclerosis component. So different cells contribute to vein graft disease, such as endothelial cells, smooth muscle cells, and fibroblasts, but also cells of the immune system, such as macrophages, T and B cells, play a role in the pathophysiology of vein graft disease. To study vein graft disease in vivo, we use a donor cable vein that is then engrafted in the carotid artery of a recipient mouse, and that's actually shown in this image here below. So what you can see directly after engraftment, there is distension of the vein graft. So actually the vein graft looks like a balloon. After 4 weeks, you can see that there is whitish spots called the lipids present on the vein graft. There's also a mild fibrosis. And important to note, there's also remodeling in length. So the vessel actually becomes larger. This is called vein graft remodeling. Also in an animal setting, we can perform micro CT analysis, and there we can visualize the vein graft. But the vein graft needs to arterialize to cope with the pressure as previously introduced. So in a post-engraftment, there is the distension of the vein graft. And then there is proliferation, for example, of the fibroblasts and the smooth muscle cells, which results in thickening of the vessel wall. This thickening can either go inward, which is called negative remodeling, or it can result in an outward remodeling, which is actually positive. These are the two extremes that is represented, and in vivo we usually see a mixture between those. So what we actually are trying to do is we're trying to induce outward remodeling, because therefore we have a lumen that's actually maintained, and therefore there's still a circulation without risk of a thrombosis or blockade of the vein graft. So one of these strategies is done via the ALK1 signaling pathway. So BMP9 and BMP10, they are two ligands for the ALK1 receptor, and they initiate downstream signaling. With a treatment we call a soluble ALK1 FC, we are actually trapping the ligand BMP9 and BMP10, and therefore preventing downstream signaling. And actually this has been shown to reduce angiogenesis in tumors. Because why is the angiogenesis actually important? Well, angiogenesis, or actually the formation of new vessels, they are also present in vein graft disease, because there is the thickening of the vessel wall. There is also ischemia in the vessel wall, which triggers the VEGF release. Therefore, with the ingrowth of these vessels, actually they have no parasite coverage, so they are considered leaky. And erythrocytes, they're actually rich in phospholipids. So due to the leaky new vessels, the erythrocytes leak out and therefore actually fuel the atheroma, which actually is a component of the accelerated atherosclerosis. So therefore, targeting of angiogenesis can result in beneficial responses in vein graft disease. So we studied this in our animal model, and actually we use therefore the ApoE3 Leiden mice. And this mice has hypercholesterolemia at a high fat and high cholesterol diet. So therefore mimicking the atherosclerosis component we see in patients. So they put on a diet for 3 weeks. They received the vein graft at day 0. Then we injected 2 groups of mice, either with ALK1 FC or the control FC. We performed flow cytometry at 7 and 28 days. And most importantly, we performed the ultrasound analysis every week until 28 days. Because at 28 days, we harvested the vein graft for morphometric and compositional analyses. We used for the ultrasound analyses, we used the Vevo 3100 laser X with the MX550 transducer, which is actually the high frequency transducer, transmitting between 25 and 55 megahertz. So to show you the vascular remodeling we observe, I would like to show you an AGV. That's an image acquired between 1 heartbeat. And actually what we see here, this is an image after 3 days post-engraftment. There is an overlay of the vein graft present, but after 28 days, we can see a clear difference in the 2 images. One image is that there is thickening of the vessel wall, and there is a decrease in lumen. And also very noteworthy, you can see that there is a curve, and that's actually the longitudinal remodeling that we're observing, because there is not enough space in the neck of the mouse to actually become a longer vein graft. Therefore, you see those corkscrew appearances. But we also can do a B mode and a color Doppler mode. So this is actually in a long axis. So this, what we see then over here, actually highlighted, this is where the vein graft is present. In a color Doppler mode, which is actually slowing the blood velocities, blue means that is away from the transducer, and a red color means that is actually towards the transducer. And here the vein graft is clearly present, as visualized with the contralateral carotid artery. But from a 2D image, we cannot really set parameters such as wall thickness or lumen area. Therefore, we need a 3D image. And with this, we can do it with the same system. So this is a movie that we made in a 3D acquisition, scanning from caudal to cranial. And here we can see that the vein graft with the carotid artery, both flanked with their jugular veins. And as you can appreciate from this image, you can see that the lumen area is quite large compared to the carotid artery. And from this image, then we can make or set parameters we use for analysis. So in a brief recap, in a control situation, we have both carotid arteries from the same size, and in a 3D maximum intensity projection, you can see that they're running parallel to the trachea. In our vein grafted model, there is a clear distinction because this is the location where the vein graft is. You can see there's a mixture of red and blue, indicating that there is a turbulent blood flow. And you can also see there's a difference between lumen area. So this part is thinner than the other part. And then we would like to set parameters for how can we quantify this vascular remodeling. So we can say we can measure areas, but we can also make volume renderings and determine the amount of volume that is actually in the lumen or in the vessel wall. So for our study, for our ALK1 FC and a control FC study, we made 3D renderings. So this is a control mouse that's actually ranged from time point 7 to time point 28, where we can appreciate the lumen in red and the wall in gray. If we put an ALK1 FC treated mouse in retrospect, there we can also see that there is an increase in wall area in comparison to the lumen. But as I already mentioned it, the longitudinal remodeling makes it difficult to interpret how is the volume then changing in time. So for this, we actually chose to go for area measurements. And the area measurements are made in 5 different locations along the vein graft. So first, we determined the lumen area, and then we determined the total vessel area. And when we subtract those, we have the vessel wall area. So from a side, you can appreciate it in this image. There we just picked 5 different locations. And that's then actually represented in a graph. And the representation is actually as a lumen area change relative to time point 7, because time point 7 is actually the first measurement that we performed. So what you see over here is that indicating that at time point 0, we have a 0 change compared to baseline. But as you can appreciate is in our ALK1 FC treated mouse, you can actually see that there is an increase in lumen area relative to time point 7, which is significantly from time point 21 and 28 days. So this is the benefit of the non-invasive ultrasound, because now we can see the change in lumen in time. But not only can we see the lumen area, but we can also see differences in the wall area. And that is represented in the figure in the middle. And there we see that there is a significant increase in the wall at time point 28. However, not significant from time point 21. And our parameter outward remodeling, which is the total vessel area, we can also see that there is a significant increase at time point 28. And of course, we'd like to validate these results. And validation is with the golden standard, the morphometric analysis. And morphometric analysis is indeed the staining of the vein graft wall. And that's actually shown in this image, and where we had a control FC mouse and also an ALK1 FC treated mouse. And this is then at time point 28. But as we can appreciate from the graph, there is no significant differences between the lumen area, which is quite surprisingly. We do see an increase in the total vessel wall area. But again, we don't see an increase in the outward remodeling at day 28. So with this, we can conclude that ALK1 FC increased the wall area, but was not affecting the lumen area in a morphometric analysis. After the morphometric analysis, we are also interested in what is the composition of the vessel wall. And that we can do by staining different cells that are contributing to vein graft disease. And for this analysis, we first stained for CD31, which is also present, on endothelial cells called the neovessels. And as we compare this to both groups, there we don't see a difference in the CD31 positive area or the total amount of neovessels. But if we switch to the smooth muscle cells, there we see actually a decrease after ALK1 FC treatment, which was significantly. The same is observed for the collagen present in the vessel wall. We also see a significant decrease after ALK1 FC treatment. This indicates that both this decrease in smooth muscle cells and collagen means that there is a less stable vessel wall. And this less stable wall is also represented by an increase in macrophages after the ALK1 FC treatment, indicating that we have a more inflamed vessel wall. So concluding from this composition analysis, we can say that ALK1 FC reduced the vessel smooth muscle cells and collagen, but increased the macrophages present in the vein graft wall. I also explained you that we are validating our responses by flow cytometry, because the vein graft is actually a local response, but we are administering ALK1 FC systemically. And we saw that there was an increase in macrophages. And so for this, we also validated if this macrophage increase was also present by a systemic response, actually by the monocyte Ly6C expression. Because the Ly6C expression is actually associated with our tissue repair monocytes or our inflammatory profile monocytes. And we plotted this as a ratio. So what we can appreciate in this graph is at time point 7 days after engraftment, we can actually see there is an increase in the amount of Ly6C high positive monocytes, which are the classical inflammatory monocytes. However, this effect is not present at 28 days anymore. So concluding from this flow cytometry, we can actually say that ALK1 FC increased Ly6C high monocytes systemically at time point 7. However, there was no difference anymore at time point 28. So in a brief summary, I've showed you that ALK1 FC treatment did not gave no differences in the plaque angiogenesis. In the ultrasound, ALK1 FC showed to increase the lumen and increase the wall compared with an increase in outward remodeling, which is actually beneficial. However, ALK1 FC was only able to show an increase in vein graft wall area morphometrically. But histologically, we observed a decrease in vessel smooth muscle cells and collagen. And we saw a reduction in lesion stability with an increase in macrophage positive area. So for now, it is clearly that there is a mechanism between our ALK1 FC with our macrophages and monocytes that is contributing to a thickened vessel wall and a thickened outward remodeling. But the mechanism is still unclear, and that's a point that we're addressing currently. But as I showed you in our ultrasound data, we measured time point 7 as our initial measurement. That's called baseline. But what we'd like to do is we would like to measure earlier. So maybe we can measure at time point 3, or maybe we can measure at time point 0 directly perioperatively. And that's actually what we did. So we were able to take measurements at time point 0. However, we had to improve some technicalities. So in our model, we made some improvements, such as a contralateral incision. We infused PBS in a surgical field to remove any air, and a suture 10-0 was used to mimic artifacts in the skin wound. And this then resulted in that we can make an absolute change compared to time point 0. So we can extract more data from our model. And next, I would like to tell you a little bit more on the vessel wall composition analyses, because this is very, very striking news. And besides the morphometric analysis that we can do, we would also like to show differences in vessel wall composition over time. And one method is to use the photoacoustics on the laser X system. And what we showed in this area in yellow, we can see the total vein graft. And in the middle is represented by the lumen. And we have a certain amount of stored profiles. So we can discriminate between oxygenated hemoglobin, represented in green, lipids in purple, and collagen in red. And if we show these single images, we can see that some of the signal is actually present in the vessel wall. And this is often aided evidence because this can be used for clinical evaluation. So not only determine the morphometrics of the vein graft, for example, the lumen area or the vessel wall thickness, but also determine the lesion stability. And it is a suitable candidate for a follow-up of peripheral vein grafts. But we are still optimizing this model by using not the unmixing algorithm, but what we try to do is we are going for spectral discovery. So what we're using is we use the spectral analyses, either in the near 1 region ranging from 680 to 970 nanometers, or in the near 2 region, so from 1200 to 2000 nanometers. And therefore, we are trying to discover endogenous chromophores. So we generate a lot of spectros. We, in collaboration with Vascular Remodeling, there was an algorithm that has been developed that is actually capable of making a componential analysis, so subtracting different kinds of spectral curves identified as components from our spectral library. And these components can then be cross-correlated with our known library. And then we can say, for example, that component 4 observed in our spectral discovery compares to oxidized hemoglobin. Or more interestingly, we can go for lipids, or we can go for collagen. And then we can actually then represent where is the collagen and where is the fat then associated with. And then the next step will be that we can make amplitude measurements or even frequency measurements of our vein graft. A small technicality is in the laser X system, there is a optic fiber that is located on the left and right side of the transducer. That's actually called the fiber side-by-side approach. And there is an deoxy profile actually run in the image on the left. Over here is the vein graft. As you can see, there is not that much signal present on the endothelial side or in the vein graft wall. What we tried is to optimize this signal, because the vein graft is just on one lateral side, is we would like to have the most illumination at that part. So what we did is we put the fibers on one side, as you can appreciate from this image. As you can see, there is a clear increase in the amount of signal that we're receiving. So this setup is actually beneficial for generating the spectral data in our vein graft model. So with this in conclusion, I showed you that we can study vein graft disease, and also we performed morphometric analysis at time point 28, but with the aid of ultrasound, we can show morphometric changes in time and therefore generate more sensitive data and more differences between our treatment groups. And to show you a bit on the photoacoustics part, so about as part of the mixing algorithm and also on the spectral discovery. And hopefully then in the near future, we can determine compositional changes in time. And with this, I would like to acknowledge especially Thijs Sluiter and Vincent Siel and Paul Kwaks and Margrethe Vries, who performed the surgeries and worked in close collaboration on everything on the machine. And Valeria Gresso on the help on the algorithm development, Joost Holthoff on the introduction of the animals, and of course, Sarah and Mandy on facilitating this live webinar. And if there are any questions, I will be happy to answer them. Or if there are any questions, you can contact me via email.
Wonderful. Thank you so much, Alwin, for that fantastic presentation. Just a reminder to all of our participants, if you have a question, please submit that to our presenter in the Q&A. We do have a few questions that have fed in. The first one is, can you explain why there's a difference between the ALK1 FC and control-treated vein grafted mice in the morphometric analysis versus the ultrasound analysis?
Okay. Yeah, indeed. So the big difference is that in the ultrasound analysis, there is an intact circulation. So there is a distension of the vein graft, and that's actually not present anymore in the morphometric analysis. So there is a bit of tissue shrinking. And therefore, if the tissue shrinks, we can see a decrease in lumen because the contractile functions are not there anymore. But the wall do not change that much. And therefore, we hypothesize that the difference in lumen in the ultrasound analysis and in the morphometrics is due to tissue shrinkage.
So in that regards, would you actually consider the measurement that you're getting from the ultrasound more of the true measurement versus the histology?
I would say yes. Yeah. And one thing we try to reduce the amount of shrinkage is via the infusion of PBS and also an infusion of paraformaldehyde. But still, you have a drop in circulation pressure, and therefore you see thinning and reduction in lumen area. Yeah.
Wonderful, thank you. In the ultrasound analysis of the vascular remodeling, why did you use the area measurement versus the 3D volumetric measurement? Isn't the 3D volumetric measurement the better parameter?
Yes, I agree. The volume measurement is more probably also more accurate. But as I briefly introduced, is in this example, the vein graft is straight, and then there is a you can set a volume per millimeter or a volume per millimeter, for example. But vein graft remodeling is also that there is a longitudinal remodeling. So in this part, it's more difficult to generate a 3D rendering because there is a curve present. And if you would standardize the amount of longitudinal remodeling, which length are you taking? Do you take the superficial length, or do you take the more deeper length of the vein graft, or maybe in the middle? So that's a bit that we're still struggling with, is how can we standardize our volumetric measurements? But for now, for this ALK1FC story, we picked the area measurements. But I do agree a volumetric parameter would be more suitable if we can standardize it properly.
Great, thank you. Lots of comments coming in saying very nice presentation, nice work. Have you analyzed the profile of macrophages present in the arterial wall, about macrophage polarization?
Yes, for this ALK1FC story we did, and I think that's regarding the M1 or M2 phenotype. And we did it by the expression of CCR2 and CD206. And we see predominantly an M1 response, meaning that 90 to 95% is expressing the CCR2 marker, indicating that we have a pro-inflammatory macrophage. And we compared both groups in the expression of CCR2 or CD206, and we did not observe any changes in macrophage polarization after ALK1FC treatment.
Great, thank you. And this next question appears to be a follow-up from the very first kind of series of questions. Have you considered perfusion fixing at pressure for the morphometric analysis for a stronger comparison?
Yeah, actually, that's currently been done. So at first, there is a pressure perfusion of PBS, followed with a perfusion of paraformaldehyde, trying to maintain the structural as much as possible. Yeah, but that's currently been done.
Great, thank you. Next question. Very nice work. Thank you, Alwin. Given the changes in the cell and the ECM components of the graft, there's a strong possibility of thrombus formation and probably incorporation. I found this in my own vein graft studies. Can you see this using the Vivo 3100? And can you see it histologically?
And then the visualization of thrombi, is that the question?
Yes.
Okay, yeah, so if the vein graft is occluded, then you can see it because then there is no color Doppler signal. And you can see it from the EKV because then you don't see the pulsations anymore. So those are two phenotypes that is or characteristics of an occluded vein graft. If it is either a thrombus or due to extensive intimate hyperplasia, that is a difference that we cannot make with the ultrasound analyses. Therefore, we need to perform morphometric and histological analysis. But occlusions can be detected. Yes.
Is that something you would be able to potentially visualize with the laser X component?
Yeah. Potentially, yes, because if there's a thrombus, it's composed a lot of hemoglobin, and hemoglobin is a pattern or a spectral curve that we can isolate from our spectros. So yes, hypothetically, we can detect hemoglobin in the vessel wall. And if the thrombi is large enough, then we could definitely see an increase. But it has not been tested yet.
Great, thank you. They have a question. Did you try to fuse the data from ultrasound and photoacoustic measurements? This needs synchronized data acquisition from these two modalities. And I think that actually just requires a little more explanation of the way photoacoustic acquisition actually works.
Yeah. So that is then regarding the composition analyses. And the fusion of both data, so photoacoustics means we're sending light in and sound reflects, and that's then detected by the ultra high frequency transducers. So there's actually a merging of the two signals that's already been done. But what we like to optimize is to use this for our componential analysis. So use our B mode and color B mode for our morphometric analysis. So visualize, for example, lumen or vessel wall changes, and use the photoacoustics for compositional changes, either in hemoglobin present or collagen or lipids. And then we can have more data from a single experiment. So the fusing is still in development because we have to focus on the algorithm and our cross-correlation analysis. And with that, if that is suitable enough for analysis, then we can run it in experiments.
Can you comment as to how many components can be identified with the algorithm for spectral discovery?
Yes. So for now, we are focusing on 7 different components, but the key parameter is actually how unique are the components. So you can ask the algorithm to have an output of 10 or maybe 12 components, but that means that 2 components can be quite similar. And is it then actually one spectral curve that is then digested in 2 components? That can be. So we need to still find the optimal amount of components, but for now we are focusing on 7 because our library does not contain more than 7 known spectral curves.
Great, thank you. And just one final question submitted through the Q&A here. On the EKV video that you presented, the P wave is missing. Can you comment as to why that is?
I think that has to do with the setting of the EKV, because it's between the systole and the diastole, and the P wave is not included in the EKV for as far I know, because the EKG is not below the EKV acquisition. So I think the EKV is just in between the P wave and the next sequential heartbeat. But that's more a technical question. I don't know if the P wave is normally included in the EKV.
Great.
So for us, we did not include it or did not include it by mind.
Great. Well, thank you so much, Alwin, for your time today. Really amazing presentation. I would encourage any of our participants to please email Alwin directly if you have additional questions, or feel free to email Visual Sonics and we would be happy to put you in contact with Alwin. Just as a reminder, we also encourage you to please reach out to us on any one of our numerous marketing platforms, whether it be our website or through social media. And we thank you so much for attending today. And thank you again to Alwin for an amazing presentation.